Hello, everyone, and welcome to our debate on restraints and seclusion used with individuals with disabilities, such as autism. My name is Carly Preisner. I will be introducing our group today. Our debate will be done in an informal fashion. So our group members include Christy from Jacksonville, Florida. She will be arguing pro-restraint. We also have Nicole from Fort Collins, Colorado. She will be arguing against restraint. We have Daisy from Munster, Indiana. She will be arguing pro-restraint. We also have Kate from Highland, Indiana, and she will be arguing against restraint. And lastly, we have Victoria from Columbus, Indiana. She will be arguing for restraint. I will also be arguing against restraint throughout this debate. First, we will start off with Victoria, who will be starting us off with some reasons to support restraints and seclusion.
So one of the main reasons to use restraints in seclusion is to benefit the individual who is being restrained or put into seclusion. So there are many other reasons as well. So preventing the individual from harming themselves and others is another really good reason for using restraint and seclusion. Also to prevent property destruction, to have a good control over the situation. It's also to be used when least restrictive methods are ineffective, such as preventative strategies have failed, calming procedures have failed. And it's also used to promote self-control and enhance coping skills for the individual. So for restraints specifically, they can be used as a therapeutic intervention to help modify inappropriate behavior. So for example, at the center that I work at, we use the BAR procedure, which stands for Brief Assisted Required Relaxation. This is actually to help the individual relax and also to prevent harm coming to themselves and to others who may be in their path. So here we can help protect people such as other students, staff, and themselves from harm. And we also use restraints for custodial purposes, so preventing any escape during a behavior or in any crisis situations. So this could be a physical hold or it could be a mechanical hold, like a seatbelt, a strap, or a jacket. So for example, if a student is in a restraint, then they can't successfully run away and potentially harm other clients.
So some reasons not to use restraints and seclusions, though, is using restraints could be reinforcing to some of the clients. If the function of the behavior is for attention or if the individual is reinforced by physical touch, using the restraints is only going to increase that behavior. This is because you are giving them that attention that they want or the physical touch that they are desiring because you are restraining them.
So if this is the case and the individual is reinforced by attention or physical touch, then that's kind of why we use seclusion, and that's why it can be beneficial. So for seclusion specifically, they have a few main purposes. So one is for containment. So it kind of helps keep a harmful situation under control so it doesn't spiral out of control. Some centers use things like calming rooms or containment rooms, which are basically, some are padded, some are not, but they're basically just empty rooms that you can put the client in so they can calm down on their own. That way they won't be reinforced by attention or physical touch like Kate was talking about. So a few other reasons for using seclusion include isolation and decreasing the sensory input. So that kind of goes hand in hand with what I was talking about with the containment rooms. So when you remove the individual from the situation, you actually reduce the opportunities for them to be reinforced by other stimuli. So the other stimuli could be visual stimuli, social stimuli, physical stimuli, peers, even auditory stimuli. So at my center, we have a client who is very reinforced by hearing other peers during behaviors. He will mimic their sound. So if we would need to put him in a containment room, that would be very beneficial to help him calm down during his behavior. So if an individual is in a behavior and is removed from that environment, they're actually less likely to be reinforced by peers or attention or physical touch.
Okay, so there are two acts of judgment that we should consider when deciding to use restraints and seclusion. So the first one is degree of unmanageability. So basically, can the situation be handled a different way? Obviously, if the situation can be handled a different way, we would want to use that method first, but sometimes it can't be handled a different way. So even when you have other proactive supports or other things in place, it's just not enough.
An argument against what Daisy just had mentioned is that ABA should Use positive reinforcement and positive approaches and methods before using any negative methods, and ABA really promotes that. So instead of using a restraint or seclusion, extinction can be used in the place of those methods, as well as response blocking. So for example, if a client was engaging in hitting their head with their hand and the function of the behavior was escape from demands, we would want to use extinction with that behavior, block it if we can with our hand, and then follow through with demands that we are placing before the behavior had occurred. If we were to restrain the client would also be able to escape in this situation, and that would just reinforce it. Seclusion also would reinforce the escape of the behavior because you're letting the child escape from the demand as well. So that's something that is good to keep in mind, because it can also reinforce the challenging behavior of hitting the head if we let him or her escape from the demand.
So the second thing to keep in mind is the degree of the danger. So is the child going to hurt themselves or someone else if we don't use restraints or seclusion? In the clinic that I work with, or that I work at, I work with a client that he finds crying extremely aversive, and he right away resorts to headbutting when there's another client crying. So we work on proactive breathing and pairing exposures with reinforcement, and we prompt mans to leave when it's too loud, but that isn't always enough. So sometimes he instantly goes into headbutting right away, and he doesn't give us any time to do anything else. I mean, he's broken tables, he's made holes in the wall, and he sometimes has gone home with a bruised forehead. So he won't stop headbutting until the other child is done crying. So I guess the question is, like, do we let him keep headbutting until the other kid stops crying, or do we block it or use a restraint? So blocking and redirecting is not very effective for him. So we need to keep him safe. And in order to do that, we start with the least restrictive restraint, and then if that one breaks down, we move to the next intrusive. And then once he's calm, we slowly fade back out. And the mom has seen the process. She's gone in, she's overlapped, and she's actually the one that made the call to say, hey, after he headbutts 5 times, you guys can go ahead and restrain him. So it's something that she's familiar with and she's completely comfortable with.
Okay, so Daisy, although that I think restraining this child is for his safety because it's preventing him from headbutting and injuring himself, there is a growing concern, however, that restraint is being used in less serious behaviors instead of just being used in emergency or in harmful situations. So we can take, for example, this week's video on the module at the Judge Rothenberg Center. The boy was said to be having aggressive behaviors, but if you watch the video, he was simply restrained for noncompliance because he wouldn't take his jacket off. So this is an example of restraint being used for a less serious behavior instead of being used in an emergency or harmful situation.
So there are some clinical outcomes for restraints and seclusion. So I'm going to start off with restraints. And the first outcome for restraints is attachment. So restraints promote a positive relationship between the individual and the holder through bonding while the individual is being held. So this basically happens because the holder is providing feedback to the individual and fading out. So in the bar procedure, after about 3 seconds, we can fade to a less restrictive restraint. And the plus to that is that that's something that's easily understandable even for nonverbal individuals or individuals that are not receptive. So they can still understand that the holder fades out to a less restrictive restraint when they're somewhat calmer. And then this leads to the psychodynamic outcome. So for the psychodynamic outcome, restraints release built up anger for individuals. So it gives them the opportunity to talk about their internal feelings by causing them to share their feelings and work towards problem solving. So in the case that I mentioned earlier about the child that headbutts right away when he hears another kid crying, it's teaching him to problem solve and understand that he could ask to leave when it's too loud instead of having to headbutt right away. And then for seclusion, the first outcome is behavioral. So basically we want them to understand that there's a natural consequence for them being removed from a reinforcing environment if they engage in certain behaviors. So the goal is for them to understand that that happens as a result of something that they did. And the second outcome is social learning. So this should allow the individual to participate in the process by using external stimuli to control their internal feelings. So basically they need to sort through stimuli and everything that's going on in their environment and decide what they need to process and what stimuli they need to ignore. And the third outcome for seclusion is psychodynamic. So this is basically the same thing that I mentioned in restraints. So seclusion releases built up anger, and it gives the individuals an opportunity to talk about their internal feelings by causing them to share their feelings and work towards problem solving.
Working in this field, it is always our goal to respect the autonomy of our clients. The use of restraints and seclusion, however, does not respect the autonomy of the individual. Restraints do not teach appropriate replacement behaviors for the challenging and aggressive behaviors that our clients are engaging in. And seclusions disclude the individuals with disabilities from their peers when they are put into the calm room or seclusion room. Before using restraint and seclusion as a treatment option, there are environmental changes that can be made to help decrease these problem behaviors. And these changes are referred to as positive approaches. They can include making the environment conducive for the client to be successful and to reduce any anxiety the student may have. This could include a large timer set at the student's desk or a visual schedule that outlines the student's entire day. Another positive approach is teaching the student functional skills, which will give the student a way to communicate their wants or needs through a means other than aggression or the problem behavior that they are currently using to communicate. The third positive approach includes setting in place a strategy for when the aggressive behavior does occur. There needs to be a detailed behavior plan that gives all staff the steps to take if the student does engage in self-injurious or aggressive behavior. And the last positive approach is to provide staff with appropriate training. It is important with every behavior plan that every staff member who engages with the student be on board and follow the same plan. This will help to eliminate any differences between staff members and hopefully, again, reduce any anxiety that the student may have.
All right, so now we're going to show you all a visual of how some restraints may be done incorrectly. So right here is an improper restraining technique. So here it's called a prone restraint, such as this basket hold that they have right here. And it's important to remember that we have to be careful when training staff members how to implement these types of restraints because they can be completed incorrectly. So this one actually here can cut off any oxygen from a person's brain and can actually cause a person to die after 5 minutes. So I think it's very important to remember how to appropriately implement these. And when training staff, you have to be very careful with teaching them how to do it correctly so that these types of things don't happen.
So like Nicole had stated before, it is very important in ABA especially that we respect the autonomy of our clients. Having said that, restraints and seclusion, we can ensure that we are respecting the autonomy of our clients by following certain guidelines when we do use restraint and seclusion. So some of those guidelines are actually set forth by the ABAI, which is the Association for Behavior Intervention Analysts International. And in those guidelines, one of the things that they set forth is that we must use the least restrictive methods to restrain an individual so that it's ethical and adheres to the ethical principles. Least restrictive means that an individual should be restricted using the absolute least amount of physical restraint or least amount of seclusion possible to keep them and others safe. So Daisy was speaking about this when she implements at her clinic that they start with the least restrictive method and then move into the most intrusive if necessary, and have procedures for withdrawing those restrictions and slowly fading out the restraints. So the BCBAs do, and as BCBAs, we will be held to the ethical requirement of the least restrictive principle. And that might look differently in each case. So least restrictive might look different for an individual that headbangs rather than an individual that fights, or individuals that engage in aggression. Like Kate was speaking of about the module that we watched this week, that would be an instance of not using the least restrictive method. For instance, like Kate was saying, that individual didn't need to really be restrained at all because what they were engaging in wasn't dangerous and could have certainly been redirected using other positive interactions and interventions. So in that case, we wouldn't say that that was an ethical restraint or seclusion. However, if that individual was harming themselves or another individual, we would advocate for the least restrictive methods to restrain that individual and keep them safe. So we wouldn't implement restraints or seclusion for a child who's non-compliant, because there's no need to restrain or seclude that child. We would only use this if it needed to be in a case where it was dangerous, or like Victoria was saying earlier, an individual was attempting to escape the room and escape the clinic and might engage in more harmful activities.
So as Chrissy just mentioned, individuals with disabilities are to be given the opportunity to be taught with typically developing peers to the extent that it is possible and appropriate. Least restrictive treatment is defined as the treatment that has the most favorable risk to benefit ratio, meaning the treatment that is most safe for the student, staff, and other peers, while restricting the student the least. So for some students, it is not immediately appropriate to be fully integrated and taught with typically developing peers. However, there are other positive behavioral approaches and techniques that can be utilized to give students the opportunity to succeed before restraints and seclusions are used. Restraints and seclusions in schools have been shown to be overused, used incorrectly, and can cause harm to both the client and the staff. So restraints that are used improperly and can cause harm to individuals when they are not used appropriately. There have also been cases when restraints have been used when consent from a parent was not given prior to the use of the restraint or seclusion, which leads to legal issues.
So now we have a video that has an example of a news report that involves restraints being used improperly, and it was actually used improperly by police officers. So here is that video.
Right, a social media post is stirring up controversy in Royal Oak, but people are asking the question, is the video telling the whole story, Glenda?
It just doesn't look good. Let's get to Ronnie Dahl. She's live outside Royal Oak Police Department. Ronnie.
Yeah, this all actually started about 9:45 last Thursday morning. That's when the call came in to the police department as well as the fire department. There was a combative student at the middle school. So the officers, along with the firefighters, who also act as the medics, responded to that school. Also there was the teenage son's mother, and she had her cell phone and she was recording. Now, this portion of the video she recorded is spreading through social media. It shows fire personnel along with police officers restraining the 13-year-old son. According to his mom's social media post, the teen has been diagnosed with Asperger's and autism. Police say the video being shared on social media sites doesn't tell the entire story. The student had been verbally and physically abusive to school staff members and his mother prior to their arrival. Royal Oak's chief of police says he wouldn't normally comment on a situation such as this, but he wants people to understand what officers and medical personnel were up against that day.
I viewed the video, and I can tell you the officers are under control. The question was raised to us is why four? You know, there's 2 firefighters and 2 policemen, and I'm telling you the reason is because we didn't want to hurt the child. If we weren't concerned with hurting the child, 1 or 2 officers probably could have got it done, but we were being very careful, and in fact, the child was not hurt.
And so the chief of police stands by the actions of his officers that day. We have reached out to the student's mother. We have not heard back from her. For the Now, I'm live in Royal Oak. Back to you.
So again, when talking about restraints and seclusions, it's important to remember that we're talking about restraints and seclusions under certain guidelines. And another one of those guidelines is that, like Nicole was talking about earlier, using the most positive method is very important in ABA and is one of our principles. And to make sure that that happens with restraint and seclusion, it's required that restraints and seclusions are not the primary interaction for the client's program, but are only used in the case of the child or others are unsafe. Otherwise, restraints and seclusions shouldn't be used. And before it gets to that point, reinforcement contingencies and positive methods should be being used to prevent those aggressive behaviors and high magnitude behaviors. Behavior programs should still utilize the same ABA strategies, and restraints and seclusion should only be utilized once other reinforcement methods have been used and have not been found effective. And so another concept that Nicole talked about was the issue of consent. We saw that also in our module that we watched this week, that the mother didn't have or hadn't given consent, informed consent over the restraint that was being used on her child. It's important to remember that the ABAI, again, they set guidelines, and one of those guidelines is that informed consent must be given. And that means more than just we let the parent know that we're going to be using timeout or we're going to be using a restrictive procedure, but that we really take time to make sure the individual understands completely what's going to be happening, when the child is going to be restrained or secluded. They're going to understand when the child would be let out of those restraints or seclusion, and that they would be informed as to what that would look like, what room it would be in, what the hold specifically would look like. We would go, as analysts, we would go above and beyond to make sure that the parent really knew at the ins and outs of the restraint or seclusion procedure, so that they could give informed consent. And as a group, when we're talking about the restraints and seclusion, we're talking about the type that is supported by the ABAI, the BACB, and this group. Those are things that we are holding strong to, the guidelines that are set forth, including informed consent and least restrictive methods.
So although in the video and the other visual, those were kind of demonstrations of improper use of restraints. And although improper use of restraints can be dangerous, this isn't usually the case. So individuals who use these procedures are actually required to be certified in such restraint procedures. And these procedures that they're certified in reflect the ABAI's methods and principles. So a few different procedures that people use for restraint that are certified include PCM and CPI, and those are both crisis management trainings. So both of those trainings use kind of a CASH criteria, as one would call it, before implementing the restrictive procedures. So CASH criteria means continuous aggression, continuous self-injury, or continuous high magnitude disruption. So before any restraint or seclusion procedures can be used, these kind of have to come into play from the individual who is being restrained. So before the use of restraints and seclusions is ever utilized, the decision also has to be made by the treatment team of the individual before it's implemented by members of the treatment team.
So these individuals that are going to be using the restraints are typically the people that are going to be working with them. So restraints and seclusions can have a very high burnout rate on the treatment team. If a therapist is constantly having to restrain their client, this can become exhausting and also very stressful to the therapist. And this can then cause a strain on the therapist and client relationship. And this can make the therapist become resentful and not want to work with the client anymore, which then can affect the therapy sessions. So then this may cause a therapist to quit. And this is why in this field it has such a high burnout rate. So for example, at a clinic I worked at, one clinic was very aggressive and he had to constantly be restrained. So his therapist then began not wanting to work with him because it was restraining him. So by having this attitude of not wanting to work with him before the therapy sessions, it affected the way he interacted with his client, which then put a strain on their relationship because then the client started to not want to work with him as well.
Another argument that is against seclusion and restraints, more specifically seclusion, is that it decreases the autonomy or independence of an individual or client. This references the Horn et al. 2013 article that we have referenced at the end of the presentation here. And it took 7 years to integrate the individual in this research study back into the community. It took 7 years. So this makes them more dependent on other people, and it secludes them from their peers, and they don't have the opportunity to learn in a natural environment, so that decreases their autonomy as well, and they end up relying on others to help them with daily tasks and completing anything independently. So it just takes a long time to integrate those back in the community if they have been in seclusion in the past.
So while it may take some time to integrate an individual back into the community or the setting from which they were secluded, it's important to utilize the cost-benefit ratio. So while this may take some time, looking at the future, it is going to outweigh the cost of the time to reintegrate, because the individual is going to have the benefit of acquiring other skills and acquiring social skills if they're not engaging in aggression and SIB and those high magnitude behaviors. So if they're consistently engaging in those behaviors, they're not getting the opportunity anyways to be integrated into their appropriate environment. So by using restraint and seclusion, it is helping the individual to then gain more opportunity, because hope in the future they won't be engaging in those behaviors. It's going to help them with the opportunity to increase their learning, increase their social skills, and will benefit them more in the future.
All right, so that concludes the debate portion of our debate. We do have some questions that just came in from the audience. One of them is that, number one here is there any procedure or training that parents can go through to implement safe restraint or seclusion procedures at home? Who would like to take that question?
I can actually take that question. So at our center, we utilize professional crisis management from the PCMA, which is the Professional Crisis Management Association. And at our center, we offer PCM training to our employees, which is kind of a full training. It includes transportation methods, vertical immobilizations, all the way to the bar procedure, which is the most intrusive procedure when it comes to PCM. So when if a parent has a very aggressive child at home, or a child that does who actually does participate in CASH criteria, so the continuous aggression, self-injury, high magnitude disruption, they need to be able to kind of protect themselves and protect other members of their family as well as their belongings too, so that no one gets hurt. So our center actually offers a PCM training for the parents that doesn't go as far as the bar procedure, but it does include transportation. So if need be, the parent would be able to transport the child out of a dangerous situation and into a more safe situation. So they can transport them, and then if they feel the need to seclude them, if they need to put them in a room by themselves to get away from other objects that can hurt them or other people that they could hurt, they can get the training in order for them to be certified to do the transportation procedures.
All right, thank you. All right, so the next one is what happens after a child is restrained? What do you have to do, or what is the process for them to get out of a restraint? And also, how and when are the restraints faded out? Who would like to take that one on?
I can take that one. So what is most important to know is that this is different for every child, and the child will know and should know what to do in order to get out of this restraint. So if you see that they are starting to become calm and you can start to back away from restraining them, or if you notice that like you start to back off and they still engage in the aggressive behavior, then you can go back into the restraint if need be. And also, so it's the same for seclusion. So everything's different. So if they're in an alone condition or a seclusion room, and maybe say they need to be calm for 30 seconds and then do a compliance test before they are able to get out. But most importantly, it is good to know and to remember that the child it's different for every child, and the child will know what to do and how to get out of it.
All right, thank you. And then the last question we have here is, what are your personal experiences in practice with implementing or seeing implemented restraints or seclusion? Who would like to start us off with that one?
I can start us off, Carly. So in my experience, we had a child in our clinic who engaged in high frequency, high magnitude aggression and self-interest behavior, around 70 to 75 of each of these instances a day. And we spent probably 6 to 7 months going over reinforcement contingencies, trying other punishment procedures, contingent effort or response cost. And it just continued to escalate to the point where mom and dad were coming in with bite marks, and it was taking a real toll on the family dynamic, and just physically it was taking a toll on both the client, his family, and his therapist. So we decided to implement the PCM procedure with him, and it's drastically reduced his aggression and self-interest behavior to the point where he hasn't had either of those behavior topographies in the last 16 sessions, or like would go 16 sessions without seeing any of that. So taking away the reinforcement, taking away the reinforcement for escape behavior or attention behavior, his function does both at times, really helped him to now acquire more skills, be in the work environment longer, so he's acquiring more communication skills. His parents are happier with both his therapy, but also just in general at home. They feel like they're able to get things done with him and don't have to live in this kind of fear that he's going to engage in those behaviors that they have a hard time controlling. So that's been my experience with it. It's been positive. The child has never been injured in restraint, and it's not no longer needed. So the goal would always be that it's no longer needed in the future, and that's what we've seen happen with this kiddo at my clinic.
All right, thank you. Anyone else have anything to add to that last question? No, we're good? All right. Then I will show you our resources that we used for the presentation here. So these are our references that we use for researching restraints and seclusion. And that concludes our debate. Thank you all for watching, and have a great day.